Hi everyone, welcome to researchmd.com. We got another great topic today. We're going to teach everything about syncope under 9 minutes. We understand how important is your time. So all the facts are in here under 9 minutes. Repetition is the key, my friends, okay? Remember that. Okay, again, my name is Pramil. I'm a program director, internal medicine residency, transitional residency. I teach medical students and medical residents. I'm also a director of research. So let's get into syncope. What's the first thing? You have to start with the definition, right? What's the definition? Transient loss of consciousness. You have to lose consciousness, and usually transient. Usually due to cerebral hypoperfusion, rapid onset, short duration, complete spontaneous recovery. Remember the word transient, a loss of consciousness, and complete spontaneous recovery is going to be there when you call syncope. Epidemiology, in the lifetime prevalence is very high. If you ask anybody, or if you take 100 people and you ask them at least if they have one episode of syncope, almost like 35 to 40% people have one episode of syncope in their lifetime. Okay. Now, when you talk about syncope, there's like three different categories we need to know. One is like neurally mediated syncope that got two parts: vasovagal syncope and carotid syncope. Okay. And then you got orthostatic syncope and cardiac syncope. What is the deadly thing in there? Cardiogenic syncope. So when a patient comes in, the first thing you need to make sure you don't have a cardiac syncope. That's very bad, a bad outcome. You don't want to miss that. All the other things, you can get away with, but you don't want to miss cardiogenic syncope. Okay, so let's look at the pathogenous syncope. There's decreased venous return, reduced ventricular filling, increased sympathetic turn, hypercontractility of the ventricle, and then you got ventricular mechanoreceptor activation. Feedback go to the medulla via the efferent vagus nerve, and sympathetic withdrawal, parasympathetic overdrive comes in. There's bradycardia, hypotension, decreased cerebral perfusion, and then syncope happen, loss of consciousness. Okay. So the risk factors are several. When you talk about reflex syncope and orthostatic hypotension, medication that lower blood pressure like alcohol use, volume depletion, pulmonary diseases like reduction in the brain oxygen supply, environmental factors like heat, and cardiogenic syncope usually caused by structural heart disease. And then you got vasovagal, emotional stress, fear, pain, venipuncture, standing, blood phobia. Then carotid sign, hypersensitivity syncope, situational syncope, coughing, sneezing, micturition, and atypical form can without any apparent triggers also. Let's look at each one. Let's look at the orthostatic syncope. Okay, it's mostly because of the movement from prone to standing position. Most likely to occur in elderly people, exacerbated by venous pooling during exercise. Mainly got primary autonomic failure like multiple system atrophy, and then you got dementia with the Lewy bodies. And secondary autonomic failure is kind of common. It's like when you have renal failure, liver failure, cirrhotic patient is like very common, diabetes, amyloidosis, and alcoholism. Then there's like volume depletion, and then medication if I got beta adrenergic blockers, antidepressant, and phenothiazine. Those medications cause it. When you talk about cardiac syncope, mainly you have to worry about structural heart disease. It's always a good idea to get echocardiogram first. Arrhythmia, again, main common like bradycardia, tachyarrhythmia, structural heart disease, anything from valvular heart disease to congenital anomalies, and then any cardiopulmonary great vessels disease like aortic dissection, pulmonary hypertension, pulmonary embolism can cause it. So when a patient comes with a syncope, the main thing you always want to make sure is like, you want to rule out this is not a seizure. So you have to differentiate like both syncope versus seizure, okay? In syncope, there's going to be diaphoresis, prodromal symptom. In seizure, you have that feeling, that aura, focal syndrome, olfactory hallucination before it happens, right? Usually syncope less than 1 minute, seizure maybe 1 to 2 minutes. Syncope, myoclonic jerk after loss of consciousness maybe. They usually don't have much myoclonic jerk, but seizure is very common. Myoclonic jerks after loss of consciousness, okay? And low blood pressure and the heart rate is in syncope, and seizure, elevated blood pressure and heart rate, rapid recovery in syncope. Seizure, post-ictal confusion is there, no tongue biting. Tongue biting is common. So in seizure, they usually have this, aura before, right? And then you got like a myoclonic jerk, and mainly the post-ictal confusion is going to be there, which is not present in the syncope. So just very important to differentiate with it. So when you look at the history of presentation, it give you a lot of clues about syncope, okay? if somebody come in and said like, oh, I was lying down, then I had a syncopal episode, always think about, the main thing you have to do is like a cardiogenic syncope. Okay, so if you're like sitting or standing, then you have to think about like orthostatic causes. In the normal sleep, it could be cardiac syncope also. You have to be arrhythmia, that's the main concern. Those are the things kind of, that give the clues about what are the causes of syncope based on the position. If somebody said like, I was standing in the heat for a long time, then then I was lying down. Or somebody said like if they're having syncope while urinating, there's like a micturition syncope is those kind of things come to play. Past medical history, think about, ask them about recent change in medication, history of heart disease. Family history of sudden death is very important, okay? Because the patient may need like a pacemaker or ICD. Prior psychiatric history, that comes to the last, and prior similar episode also. Medication, again, we talk about recent changes in the medication, antidepressant, antipsychotic medication, antiarrhythmic medication, all of that important, okay? Physical examination, always look for the physical examination. Mainly, we talked about before, looking at syncope, you have to differentiate from seizure, right? Always kind of look in the mouth, see if there are a cut in the tongue, or if they have seizure, they usually like on the floor, kind of going back and forth with the jerk. You can have like scratches on the back, those kind of things. To rule it out, it's not a seizure. You always do the orthostatic to make sure. I mean, very, very important to do the orthostatic, okay? Because to make sure it's not orthostatic hypotension. Cardiovascular, you look for murmur, arrhythmia, carotid bruit, those kind of things are important. Neurological, look for to make sure the patient didn't have a stroke, any kind of focal deficit. Vascular, we talk about bruit. Gastrointestinal, always make sure patient is like losing blood and all that. Diagnostic studies, main thing, you have to do like basic laboratory work like cardiac enzymes, BNP is also important. Electrolyte abnormalities are important. ECG, echocardiogram, CT, MRI. Usually patients getting several tests, and most of them they don't usually kind of show any results. So it's very important. We'll come back to a risk stratification model before you do a lot of tests worth the millions of dollars. Okay, lab tests we talked about, targeted lab tests, maybe hemoglobin, you got troponin, D-dimer to make sure patient have like, I mean, only if you're suspecting pulmonary embolism, then do a D-dimer. Okay, glucose is very, very important, HbA1c, and in unusual causes, you can look at the other causes, but mainly you have to do the CBC, CMP, troponin, and the BNP. Those are the things important. Okay, ECG should be done in all patients with syncope because you want to rule out arrhythmia. Sensitivity and specificity pretty high, 86 to 70%. The next thing you have to do when a patient comes with syncope, always do the San Francisco syncope rule. So you can see it's a very serious syncope or not, because again, we're trying to rule out cardiogenic syncope here. So what are the things they're looking in there? Congestive heart failure, hematocrit less than 30%, ECG or cardiac monitoring abnormal, shortness of breath history, systolic blood pressure less than 90, okay? So these are based on this, you can predict the serious outcomes like death, MI, arrhythmia, stroke, pulmonary embolism, and the sensitivity of San Francisco syncope rule is 98%, specificity is 56%. So if you have low San Francisco syncope risk, you can pretty much discharge patient from the ER, so you don't have to do the million. But if the risk is high, then you have to think about doing all those investigations we talked about. So the treatment is different, depends upon the neurally mediated syncope, reassurance, education, and all that. Orthostatic hypotension, education, lifestyle modification, and the cardiac syncope, you have to look at the cardiac causes. Thank you so much for watching. We'll be back with another presentation. Please subscribe to our channel. Thank you.